A very good evening to all of you streaming in. This is Better Why, hosted by the Rotaract Club of Colombo East and Colombo YMCA. Let me give you an introduction on these proceedings, ladies and gentlemen. Better Why is hosted as a collaboration between the Youth Development Committee of YMCA Sri Lanka and the Rotaract Club of Colombo East to present a platform for young people to raise awareness about social issues and topics pertinent to the future they want to see. The YMCA has a long history of working with the youth and the field of youth development, and has always found itself at the forefront of tangible change. In Sri Lanka, its history can be traced back to 1882, 138 years to the date, and the National Council has provided leadership and societal change since 1962. Likewise, the Rotaract Club of Colombo East, as one of the premier Rotaract clubs in the country, chartered in 1989, has built a reputation of finesse and articulated action as a youth-led social service and self-actualization platform par excellence. Ladies and gentlemen, the initiative Better Why has four objectives in general, if I were to call them out. Firstly, to create a platform where the young people are given an opportunity to explore burning issues relevant to the youth of Sri Lanka, to create an understanding on matters that are perceived as taboo in Sri Lanka, to raise awareness on the role of young people who can play an alleviating role in these issues, and lastly, to identify possible avenues for young people to contribute towards intergovernmental review of the implementation of policies that can mitigate these concerns faced by the youth. Ladies and gentlemen, today in conversation is yet another social taboo that is of paramount importance to be put under discourse. Before we move into the specifics, I'd like to mention and remind everyone of our digital media partner, Daily Mirror Online and Lanka Deepa, as well as our event partner, Flexus Labs, for their contribution towards Better Why. Without their contributions, this project would not have been possible. So thank you so very much for your contributions towards Better Why, organized by the Rotaract Club of Colombo East and Colombo YMCA. Ladies and gentlemen, the conversation at hand today is a topic that will put into question humanity as a whole. We as a race and a civilization have had a history of creating conflicts for the most insignificant reasons. And right now we are going to discuss a social taboo that has led to certain marginalizations, discriminations in society, that has led to some people even taking their lives. Many victims of this infection have proclaimed that it is the discrimination more than the disease that has led to frustration and agony. So, ladies and gentlemen, we are going to discuss our social obligation, our moral obligation, when it comes to sensitive issues such like this. Ladies and gentlemen, the topic at hand for today's discussion, the stigmas and discriminations that surround the human immunodeficiency virus, better known as the HIV virus. And other sexually transmitting diseases. Ladies and gentlemen, we have two exceptional panelists here with us today who have taken times out of their busy schedules to create some enlightenment within the youth of tomorrow. So without any further ado, presenting to you our exceptional panel of exemplary personalities. To start off, Dr. Ariyaratna Manatunga, having graduated from the Faculty of Medicine, University of Colombo, and obtained a Master of Science and a Doctor of Science from the Postgraduate Institute of Medicine, University of Colombo. He is a board-certified medical specialist in venereology. He's an honorary fellow of Sri Lanka College of Venereologists, Postgraduate Institute of Medicine, University of Colombo, Sexual Health Services, Royal Adelaide Hospital, Australia, and Hubert Humphrey Fellow of the United States of America. He's a past president of the Sri Lanka College of Venereologists and currently serves as the chairperson of the Board of Study in Venereology at the Postgraduate Institute of Medicine, University of Colombo. He has been working as a consultant venereologist in the National STD/AIDS Control Program since 2003. And in addition, he serves as the head of the Strategic Information Management and Online Outreaching at the National STD/AIDS and Control Program. Dr. Ariyaratna, thank you so very much for being with us this evening. We are so grateful to have you here, and we apologize once again for the technical difficulties that led to a delay. Thank you so very much for being patient with us and staying with us here at Better Why. Our next exceptional panelist joining us tonight is Mr. Shriyal Nilanka, currently a program officer at the Family Planning Association on a global fund, funded regional agent grant to support the national HIV response in Sri Lanka. He's also a PLHIV, which stands for People Living with HIV activists, and a member of the queer community. Mr. Shriyal Nilanka, if you can turn on your video camera, introduce yourselves to our viewers. Hello, Mr. Shriyal. Thank you so very much for being with us this evening and enlightening the future of tomorrow. If I can invite both panelists to please turn on their video cameras and join us in the conversation of stigmas and discriminations that surround the HIV virus and its victims. Ladies and gentlemen, I want to present the first question to Dr. Arya Ratna. Doctor, could you give us an introduction of what HIV is and how it affects an individual? What are the other sexually transmitted diseases which currently poses a threat to society we live in? Sir, the floor belongs to you.
Okay. Good evening to everyone. And first of all, thank you very much for inviting me. As you already mentioned, HIV stands for human immunodeficiency virus, which was first discovered 40 years ago, that is 1981. But HIV is still one of the deadliest and most persistent epidemics of which affect humankind. Now, for example, even as of today, there are nearly 40 million people living with HIV in the world. And in 1 year, around 2 million people newly infected with HIV, and about 1 million people die due to AIDS-related illnesses. So it is still a big problem, even after 40 years after discovering HIV. You know, during this time, a lot of epidemics, pandemics came and they went, but HIV is going to be still is a big problem to us. Now, when you come to Sri Lankan situation, we estimate that there should be around 3,600 people living with HIV. And of these, only 64% we know that we have diagnosed them. Others still we have not diagnosed. And currently in our treatment centers, there are nearly little over 2,000 people on HIV medicine. So that is the Sri Lankan situation. So what happens when HIV infect somebody? It attacks that person's cells which maintain the immunity or the ability to fight infections. So over the years, if we do not start on HIV medication, that person's ability to fight infection goes down slowly over the years, and it comes to a point where it is very weak. That stage we known as AIDS. But if you provide the HIV medication, we call it antiretroviral medication, people should not develop AIDS at all. We can, with HIV medication, we can control the virus so that people can live healthy and also can lead a productive life. So that is the situation, but unfortunately, at the moment, there are no medication available to cure HIV. So if someone gets HIV, that person has to live with HIV for the rest of the life as of now. So you never know, in maybe 5 years time or 10 years time, there can be a cure. But as of now, if somebody gets HIV, that person has to live with HIV. And as soon as that person start on HIV medication or antiretroviral treatment, better, because that person's immunity is preserved and that person can live a healthy and productive life. So how this HIV transmit to somebody? It is transmitted through contact of certain body fluids from an infected person. So usually this happens by having unprotected sex with the infected person or through sharing injecting equipment. Now, when I say unprotected sex, that means sex with an infected person without using a condom or without having HIV medication for either to prevent or treat HIV, because if that person is on treatment, then the viral load is so low and there is hardly any risk of spreading HIV. Now, so there are, I already mentioned you, there are HIV medication which if somebody is HIV negative, they can take medication and prevent getting HIV infected. Or even after the exposure, there are medication, if you take it properly, you can prevent getting HIV infection. In addition to condom, these HIV medications are there. So it is raining over here. I don't know whether my quality of my, there is a lot of background noise.
We can hear you fine.
You can, okay. So this is regarding HIV. So in addition, there are other sexually transmitted infections.
Yeah.
Now, there are nearly 20 organisms which can predominantly transmitted mainly through sex. But of these, there are 8 diseases which are commonly quite common. So out of these 8, there are 4 STIs, or sexually transmitted infections, which are called curable HIVs. That means we can cure them by giving an antibiotic. So they are syphilis, gonorrhea, chlamydia, and trichomoniasis. And there are other 4 viral STIs, viruses, sexually transmitted infections due to viral infections. They are herpes infection, herpes, we call genital herpes, and infection due to human papilloma virus, that is Wart virus, hepatitis B virus, and of course, HIV is also one of the sexually transmitted infections. So those 4 diseases you can't cure, but of course, there are medication available to reduce their symptoms and signs, and we can make them better. But unfortunately, those 4 diseases, we can't totally eradicate, or we cannot cure them. But now, unlike HIV, these viral infections, they won't have any lasting, they are not life-threatening. They won't affect, they won't, they are not leading to death. So basically, that is a very brief introduction about HIV and STIs. Now, STIs, some of these ones are just, 1 dose of antibiotics can fix them. But there are other social and psychological effects. They are more significant than the medical problem itself. For example, in case of gonorrhea, you can just give one dose of some antibiotics and we can cure it. But then, you can infect your partner, and then the partner can infect their children. And likewise, there are so many family and psychological effects. They are beyond the medical problem of those diseases. So that is a very brief introduction about HIV and STIs and how they affect people.
Thank you, Doctor. That was very insightful. This next question is to both our panelists present here tonight. I'd like to start this conversation with Mrs. Shriyal. In your opinion, why is there discrimination against victims of HIV and other sexually transmitted infections?
Okay, so Ritika, I've been living with HIV for the last 8 years of my life, closing upon that amount of time. And in my opinion, I understand that people have a innate fear associated not only with a disease of any sort, but also when that disease is somehow linked to a community that is not you. There tends to be a form of disassociation, because you kind of try to understand it as something that is not something that is affecting you, but rather that particular part of community. And I think it's quite a loaded question and quite a loaded issue, because we as Sri Lankans have been othering certain communities that are vulnerable for HIV, and it has been quite easy for us to sort of put it past saying that, oh, this is not something that is going to be affecting me, rather this is something that is affecting them. And so along with other social marginalizations, it has been easier to also sort of pin HIV on certain communities and put it past, and it's been easier to kind of disassociate general population from those who are at high risk or who have been affected for HIV. So, I mean, it's sort of bringing these social marginalizations and then also linking it with HIV itself. It's been easier to sort of keep people and communities at a certain distance. And when you take the understanding back into the communities that are affected, it's also a fear of I do not want someone who is either living with HIV or who has some connection to it to be associated with me, even though I am still part of this marginalized community. So this is also sort of a second layer of stigma and discrimination that a person who is living with HIV, a person who has any association to a person who's living with HIV, or any sort of proven or sort of how would you say it, ideated or like you suspected sort of association to HIV, then has to also go through that added layer of stigma from their own communities that they're part of. I don't know how far you've been sort of following my Instagram stories and things like that, but even as a part of the queer community, I myself have been subjected to a layer of discrimination over the years, just because people are perpetuating that fear that here is someone who is living with HIV, walking among us, potentially, threatening our existence even within the community. So it's multiple layers. It's very hard to pinpoint and say where it comes from. It's fairly easy to generalize it and say, okay, we haven't had a successful communication since the fear campaigns that we used to run back in the 90s. I don't know if anyone, I'm sure Dr. remembers the campaigns which was a miss in our sort of intervention when we said AIDS marantikai or AIDS kills. However, there hasn't been the same level of will among all stakeholders to, or the resources actually, Ritika, because look at it this way, right? There is a limited pool of resources that we have for our prevention, as well as our treatment services, as well as encouraging people to sort of come in for testing. So you have to sort of prioritize where you put this money into. We haven't seen larger commitment towards shifting the narrative around HIV, which unfortunately is why someone like me who has no sort of ulterior motive to be a part of this conversation have put not just my own well-being, but also the well-being of people who are associated to me, and sort of publicly standing out and saying, narratives are shifting, understandings are changing. So let's move towards slowly sort of evolving our conversation. So this is it's a layered issue. It's the for example, it's the criminalization, it's the lack of communication, the lack of resources, the lack of will for that. Um, so in my opinion, discrimination against victims of HIV, other sexually transmitted infections is a whole other problem that I don't want to talk about right now, because that stems from a refusal to accept that people engage in sexual activities, and education around that has to be expanded.
Yeah, for sure.
I mean, we can trace back to how the pushback around educational sort of materials have been, and the lack of acceptance from community leaders who have to sort of take initiative in terms of pushing these messages have stood as the barriers to educating the youth. And which is why I think now initiatives like this have to have come forward to sort of take the responsibility of safeguarding the youth as well as the communities. So these are multiple layers of social issues that have been in play.
If I can ask you a follow-up question to what you just said,
Sure.
will you point this problem to an issue of selfishness amongst people?
Could you elaborate on selfishness?
Where one will prioritize oneself over others, compassion. Instead of that, you think about yourself, it's self-centered, selfishness. Would you direct it there when it comes to discrimination against victims?
I wouldn't say selfishness. I wouldn't say selfishness. I think it's rather protecting self-implied moral values.
Okay.
Then, because I mean, if it's selfish, in a sense, we could frame what I am doing as selfishness as well, in that sense, because I am trying to safeguard myself as well as a whole other community that is coming behind me to have a better life. But the biggest barrier that we seem to end up facing is a self-imposed, I mean, I want to say self-imposed, but it's also sanctioned in many other ways by other institutions, but rather it's a moral code that we have adhered to, ironically, which is not ours, but yet we have taken it on as a crusade, as a third world country that was colonized, which, if you trace back, has no sort of roots in our own culture. So we are not really safeguarding something that is inherently ours, but rather something that was sort of given to us. And through those sort of trickle-down moral values that we've now built this sort of pseudo understanding of who we need to be as a culture, which is rather ironic and short-sighted, but nonetheless quite powerful also, because it's mobilizing an entire segment of people to perpetuate hate against multiple other sort of marginalized communities. I mean, it's very sinister, but it's there, and which is what sort of stands in the way of change. It stands in the way of introducing innovation. It stands in the way of the larger sort of goal of public health. Absolutely. So I think, which is why even people like Dr. Ari has taken the initiative to restructure the narrative, to restructure the priorities around, it's not about a particular community, it's not about a particular disease, it's not about a particular time in our lives, but rather it's keeping the generalized population safe. We are looking at all of this so that we can bring multiple sort of stakeholders into under one common goal, which is public health issues. We are a country that is providing public health services free of charge, and there is an economical sort of burden that not adhering to or not adapting to such a sort of better innovations that are being introduced. So we're trying to restructure it under one of few common goals, and try to make it seem relatable for everyone, because understandably everyone does concern themselves with their health as well as their children's health. So now let's bring it together and say, if you stand in the way of certain things, you're not only standing in the way of current initiatives that are being introduced to safeguard the public, but also those of that will come after you.
Absolutely. Thank you so much, Mrs. Shreya. The same question goes to Dr. Ari Ratna. I'll repeat the question for your benefit, sir. In your opinion, why is there discrimination against victims of HIV and other sexually transmitted diseases?
Okay, this is, I mean, now even the use of terms, the term victim, I mean, HIV is just like any other medical condition, like an infection. For example, if somebody is having hepatitis B or C, you don't call a victim of hepatitis C or something. It is just a person infected with that particular virus or disease. So even here, the term victim, it implies that, there is something unusual about HIV. So as Shial correctly said initially, fear is one of the root cause of some of these things. You can't justify it, but in 40 years ago, when HIV first discovered, there were a lot of healthy young men, especially, they were keep on dying without apparent no reason, and then only all these discoveries, the virus, the treatment, they became. So initially, it was so people always associate HIV/AIDS with death. And still, unfortunately, this inaccurate information is there. So people think that if you deal with somebody or work closely with somebody with HIV, you have a personal risk of getting HIV. You understand? But now, thanks to the medical discoveries, now because of HIV medication, even unprotected sex, I mean, condomless sex with a person with viral suppression, you can't get HIV. So now the situation is different, but still people are, maybe because of inaccurate information and, lack of whatever understanding, people are still, they are now even people think that they might have the slightest risk of getting HIV through sharing certain thing with people. So it leads to kind of discrimination and trying to separate those people. And also the other thing is a lot of people associate HIV because of the some people do not like certain behaviors. For example, homosexuality or drug use or sex work or infidelity. They always associate HIV and other STIs with these behaviors, and then they try to be judgmental and try to be moral and all that. And also some people saying people get HIV because the people are irresponsible and so they should be punished, and that kind of false beliefs and things are still there. So they are the root causes of this stigma, and then stigma is it is just your psychological status, and it can be self stigma. The people who have HIV can have their own stigma, and also then others can have other people can have stigma on others. And then when you enact it, when you try to implement certain things, when you try to discriminate people, then the discrimination comes. So it is a complex thing, but unfortunately, it is present in various degree in most of the countries. I don't think there is a one country total free of stigma and discrimination. So those things are because I have some international experience, and even in those countries they are not zero. But then there are systems are in place, just to address certain issues like discrimination. Then they won't. There is zero tolerance to discrimination. So in countries like ours, still we have to improve these systems and the laws and stuff like that. So that is my opinion or view about this discrimination against people with HIV and other STIs.
Thank you, Doctor. This next question goes out to Mr. Shriyal once again. As somebody who is both HIV positive and an activist, excuse me, have you faced discrimination personally, and in what forms do HIV positive patients face victimization and other forms of discrimination in Sri Lankan society? So kind of a story sharing question. Yeah.
I mean, I don't want to go on and on and on about this story because I've been repeating my stories. But yes, from the point of receiving my HIV status to just this afternoon, like it's been a non-stop journey of sort of having to deal with the fear of being a threat to people, right? Because I mean, I can't outline just one. Look, see, the thing is, from senior medical professionals sort of passing judgment on my lifestyle, which has been documented as part of a I don't want to say alternative, but a sort of let's put it as subculture, right? It's a alternative. I'm lost for words to explain my own lifestyle, but the understanding is that something that is not mainstream, something that is not largely or widely accepted, has been always past judgment, with and within, as well as from outside. So starting from getting my results from even a private hospital to having to seek medical services in the private hospitals, just to learn that there has been a policy in place among private institutions or private health institutions to refuse treatment for people living with HIV, or admit, in a country that we love to harp about how accepting and how kind and how sort of benevolent we are as a society, right? To not giving to sort of not giving a split second to understand what the other person, who is obviously, who has the means to pay for it, but rather has no choice but to sort of walk away from the medical institution because you simply choose to take on some of the science, which is what your whole institution is built around, but yet also use some of it to sort of perpetuate hate, right? And sort of bigotry on a community, which clearly is requiring medical assistance. That's a huge problem. To people within communities feeling that it's their moral obligation to ask people to go and kill themselves, or to sort of disallow people into spaces because they feel that they are upholding some God-given right to them. Sorry, I'm losing my cool because these are very personal things, right? When someone keeps asking you to go kill yourself, it's very difficult to not take it personally. I do try to keep my demeanor fairly diplomatic when I respond to them, but like, I mean, how much can you sort of keep fighting to sort of be a part of society when science itself backs your existence as sort of not a threat, yet you have to deal with sort of sometimes the limitations of the human ignorance, or actually no, the expansion of human ignorance, but limitation of sort of your acceptance, or to shift your understanding, right? Like, I mean, I hope doctor would not take this personally in a sense, but we ourselves have understood that, we take certain parts of science, like, for example, let's put it this way: within our sort of system of care, we accept the HIV test, we accept the HIV treatment, but then we dismiss 20 years of research that is done to say that, like, when someone has an undetectable viral load, it's untransmittable. I think Dr. Ari has been one of the pillars and sort of pioneers to keep pushing this message among the doctors, to keep shifting this understanding that, you have to work with science. You are taking everything that science has to offer from all these other countries, but you refuse to then sort of take certain parts of information that comes out of it because it doesn't now sit with your general understanding of what the disease has been. So it's an ongoing sort of evolution of scientific information versus human, or the limitation of what humans want to sort of do with making spaces available and sort of actually being accepting towards other communities and sort of understanding where their complexities come from. So it's an ongoing sort of process of learning, unlearning, and teaching others of what you have come to understand.
Thank you so much, Mr. Shriyal. This next question I present to Dr. Arya Ratna. How do these issues affect the well-being of the victim in the long term? Discrimination, stigma, so on and so forth.
Well, basically the ultimate, we are trying to, as medical profession and, the healthcare workers and all that, we are trying to make, ill people well, I mean, we want to get rid of sickness, but then as long as this stigma, discrimination, those things are there, ultimately we won't be able to achieve that objective. Now, for example, because of this stigma and discrimination, a lot of people lose their livelihood. For example, they might not be able to do their same job, and they might kicked out of their jobs, and even within their own homes, they might not get the same care that they used to get. For example, if you get a disease like cancer or heart disease, your family, your parents, your loved ones will look you after. But in case of HIV or even STI, that because of the stigma and discrimination, you might just get the opposite of that, right? So you might get rejected even from your own family. And then people, and also, the prospects of getting married or having children to, some people, that may be the most important thing. So those opportunities might lose as a result of this stigma and discrimination. And people, lose hope. Now, Sriyal, of course, a strong character, I would say. I admire him. But there are a lot of people are not that strong, they just get depressed, and they think, it's worthless living and all that. And so they stop being, a healthy, positive person, and they might self-harm themselves, so they might take revenge from others. So there are a lot of unwanted effects due to stigma and discrimination. However, when we are when we say stigma and discrimination, we always think that it is societies or other people's attitudes or the actions towards person living with HIV or person with STI. But there are certain studies done on this area, stigma and discrimination, and nearly 40 to 50% of the stigma is what is called internalized stigma or the perceived stigma. So they themselves think it's others will think about themselves badly, and they don't seek treatment, or they don't come forward for testing. So it is kind of internal stigma. So then to avoid these things, we have to educate people regarding, for example, if you get people living with HIV, we have to educate them about their rights and their, what they should get, and what are the facilities available, and what are the actions that you can take in case if if there is a clear act of discrimination, because it is not allowed, and there are what are the places where you can make a complaint. Now, I know Mr. Shial is trying his level best to, go all the way, doing all these things. So the thing is, if everybody get together and do it, it will be more effective. Otherwise, if just 1 or 2% is trying to do this, everybody think that, there is something wrong with this person. By others are not doing, so they think, they are doing okay. Because of this, just one person, he is different. So the thing is, everybody should, we have to educate everybody to make, raise their voice and all that, and do the necessary action if there is an incidence of discrimination, especially. Because stigma is something internal, either in the affected person nor the other people. So it is something, some people, certain things are, hard coded when we are born, we have our own values and systems. For example, things like religion, religious values, they are hard coded and very difficult to change, and we don't want to change. But you can have your own values, but when you work, you should not discriminate other people based on your values. Your values are for you and maybe for your family, but not for your clients and your customers and your patients.
Yeah.
That message has to be given to all the people affected by these diseases, so that they can get together and raise a voice and do something.
Dr. Arathan, just to get an understanding of what the state institutions look like, a question is on my list. What are the health mechanisms and other structures in place to assist in the diagnosis and treatment of HIV in Sri Lanka? And if I may also add to that, what is the nature of the staff in these treatment institutions? How do they treat the patients? And what is the environment, the internal environment?
Okay, the first one, what are the mechanisms available to diagnose?
Yeah.
Now, when you get, HIV, for example, diagnosing HIV is quite, simple. It is just having a HIV test. Otherwise we can't wait till they get symptoms and all that. If there is a kind of a, potential exposure which might get HIV, it is always, good to have a HIV test. That is the only way to confirm that whether somebody is having HIV or not. So what are the mechanisms available? Both in the public sector and private sector, healthcare providers offer HIV testing. Now in the public sector, when you go to public sector, it's usually, we have a set of 40 STD clinics situated island-wide. There are staff who know about this HIV testing and the sensitive issues and all that, and it is not a big issue. Then people ask them and they give it, and they are waiting till somebody comes and asks them, please test me for HIV. Whereas, a general physician might not, it might, surprise sometimes, why this person wants HIV or something. But for STD people, that is their routine job and they are more familiar. But you don't have to go to STD clinic itself. You can, you can go to a general hospital and they might take the blood sample, but usually they send the blood sample to STD clinic. But now there are what are called rapid tests. So it is just a strip test. From our program, we have given these tests to most of the hospitals. They can do the test and give the result within 20 minutes or so. Excuse me. And the private sector, of course, again, private hospitals, GPs, anybody, if you can, so they will order a blood test, and you can go to a lab where they do it with the prescription. They will do it. Now, this is the system so far, but now this new mechanism, new concept of HIV self-testing has come. Now, for example, if somebody want to know whether you are pregnant or not, then there are test kits which you can buy from pharmacy or from a supermarket and do the test at your home and know whether you are pregnant or not. Likewise, these HIV self-test kits are also available, and you don't have to take a blood sample. You can just do it by your oral fluid. You just contact with your oral fluid, not saliva, but you take a sample from your gums. That is called oral fluid. That is called, there are different trade names like OraQuick. Now, from this year onward, we are trying to promote that. So far, that was not available. It was done only in, testing kind of study kind of scenarios. But from this year onward, we are going to start that facility also, because there are some people who do not want to go to a doctor and say that, they need HIV test. Some people are shy or scared or whatever. So those are the things available for diagnosis. The important thing, the advantage of going to a doctor who knows about HIV is that the doctor can, before testing, can give some pre-test information. Like, for example, some people say, they had unprotected sex just 3 days ago, and they expect to do a test and know whether they got HIV from that particular exposure. But a doctor can say, if you do this test, it will catch things happened so 2 months or 3 months ago. So that's called as a window period, that depending on the type of test you do. If you do a molecular test, after 2 weeks you can get diagnosed. If you do, antigen antibody combined test, 3 to 6 weeks you can get. But if you do only antibody test, it might detect only infection that happened 3 months ago. Likewise, doctor will give some advice. You have to wait 2 weeks more, 2 months more to do this test. And even after getting tested, uh, if it is negative, doctor can give advice how to stay negative in future, and whether you need to do a test again. How can you keep negative for in future? Likewise, doctor can discuss. And also, in the unlikely case, if it is become positive, then doctor will recommend you do this test to confirm and refer the patient if necessary. So that is the advantage. If you do it, self-testing at home, maybe you are on your own. You, even if you get a false positive test, you will assume that, oh, my HIV test is positive. Now what I'm going to do? Who is going to help me? So people might face a big problem. It may be just a false positive test. So that is the advantage. So the pros and cons are there. So, but we have to promote both these tests so that the relevant people will get whatever the thing necessary. So regarding the treatment,
yeah,
so we'll say you start treatment once you get confirmed that you have got HIV. Because initial tests are usually screening tests. After that, you have to do a confirmatory test to make sure that you are actually got HIV. So once you are confirmed as having HIV, then at the moment in Sri Lanka, only the government provides this antiretroviral treatment. Public sector is not investing on antiretroviral treatment because it is a considerable amount of money. Cost has to be borne by the infected person, and it is a lifelong treatment. And often those who become positive, might not be able to work, or they might lose jobs, and they might, lose even their family. So they only few people can afford to spend large amount of money for the rest of their lives on treatment, because treatment is not only the cost of the tablet. You have to have regular blood tests to see whether your immune function is improving and whether it is maintaining in optimum way. So those tests are a little bit expensive. For example, viral load test, that is the amount of virus in your blood. That test will cost about 10,000 bucks. So that is only just one test. There can be 2, 3 tests. So everything coupled, the patient will have to fork out fairly significant amount of money. And fortunately, our numbers are small, so the private sector thinks that it is not profitable, because if you get down drugs, then you have to expend, otherwise it will expire and they will have to bear that cost. So at the moment, no private sector hospitals are offering antiretroviral HIV medication. So it is the government STD clinics, and in addition to STD clinics, IDH clinic also has a clinic. But because of now COVID situation, HIV clinic get less attention, and most of the people are getting treatment from the STD clinic. So there are 39 STD clinics which offer this HIV medicine. With the IDH, there are 40 centers island-wide. Still, it is not perfect, but almost all districts, at least one clinic is there. So it is all investigation costs, the treatment costs are provided free of charge. And from time to time, when we get a grant, we even, reimburse some of the traveling costs to these patients. So, and also if there's a mother who delivers a baby who is HIV, I mean, HIV positive woman delivers a baby, then, we even provide support to provide, this formula feeding to the baby. Likewise, there are, so it is in most of the countries, this free thing is not there. So they sometimes they think that, Sri Lanka is having a very good system in case of, everything is free. Most of the countries, they have to pay. But as Sriya said, still we have to improve a lot regarding to improve the quality of our, the attitudes towards patients and all that. But we are doing a fairly good job of, providing, and also all the trained doctors are providing treatment. For example, in India, for example, even, mid-level healthcare workers are providing antiretroviral treatment. But in Sri Lanka, only the consultants, the specialist level doctors are prescribing ART. So those who have had, overseas exposure and all that. So the young doctors, they have much better attitudes compared to, older generation doctors.
Yeah.
And things are improving in overall. That is a brief overview of the diagnosis and treatment facilities available.
Thank you, Doctor. This next question is to Mr. Shreyal. How effective has activism been in changing the social mindset and mitigating the stigma in Sri Lanka?
Well, I mean, okay, so it has brought about a lot of positive shifts towards better services. And I think in that sense, Ritika, the national program also has had some level of, I think it's also, as Dr. rightfully said, a lot of the specialists have foreign exposure. They have an understanding of how the global standards have been set, right? So some things like, say, for example, access for transgender services, acceptance of trans persons as a community to have their own vulnerabilities, which requires a sort of differentiated approach towards a prevention mechanism, which means you have to identify that there are certain vulnerabilities that they as a community face that are directly sort of affecting the treatment and prevention services. Hence, you have to take on these sort of intricacies within your own program to look at how to mitigate some of these other vulnerabilities. So taking that into consideration and taking the numbers, yet the level of acceptance that the national program has had is a direct correlation of the activism that the HIV key population communities, as well as the transgender communities, as well as sort of a regional and global push towards more accepting services have had on the entire national program in general. At the same time, there aren't a lot of preconceived there aren't any legislative or preconceived sort of oppositions around it. What I've noticed is it depends on the kind of issue that you're trying to change within the HIV prevention program and the level of sort of will on the sort of opposing sides has a direct correlation of how much has changed or how much will change in the future and what is possible to change. But yet, there is a sort of really good relationship. I mean, it's a sort of ongoing sort of development of relationships that have led to learning from communities. Also, see, I've tried to point this out in reference to the current COVID situation. The HIV sort of epidemic or the pandemic situation has had a sort of humongous, that's not even a word, but a large understanding from community-led interventions. And we've tried different sort of methods of prevention, working with communities, listening to communities, which is directly coming from activists, to say that certain priorities should be made and met if you want to address some of these sort of vulnerabilities in order to successfully lead some of these preventative methods. And we have those understandings, and we have now shifted within the HIV prevention program to prioritize community interventions, to look at community vulnerabilities in order to sort of successfully convince people that some of these sort of preventative methods can only be adapted only if you do pay special attention to these community vulnerabilities. So, which is something that we have an understanding and, I mean, decades of learnings, which ideally could have helped us at this point. So, unfortunately, there isn't a large sort of again, we were facing this. It's a repetitive cycle of sort of having to go through the grind in order to get people to listen to sort of people who are saying, you know, if you want to reach certain objectives and goals, like reduce the number of sort of cases or get people to be more responsible, that sort of symbiotic relationship between state as well as community has to be fostered. And the only way that we've managed to do that is through champions who have been sort of leading for years and years on various sort of fronts, from issues such as LGBT sort of acceptance to sort of looking at transgender persons in a more sort of sensitive manner, or to sort of understanding that decriminalization of certain behaviors such as drug use or sex work or same-sex sort of conduct could potentially lead to positive sort of health interventions. This ongoing conversation has been happening, and it has informed the programs that the state has been running. And we've been fortunate enough to have time on our hands in that sense to have, and also knowledge from other countries that has been shared with us in similar interventions. So it's been easier to prove that, you know, if you implement some of these services, for example, if if as activists we go and say PrEP is something that is required for the community because we are seeing a whole other level of vulnerabilities popping up within the communities, and there is science to back this up. There's also other interventions led by other countries to back it up. As activists, I'm pushing myself out of the program for a minute. It has helped us sort of convince the HIV programs to adapt some of these interventions. So it is a ongoing sort of relationship that has been built and fostered way before I have ever been sort of even diagnosed. So I'm just another sort of part of that link that has, in this moment of time, that is sort of providing support. So yeah, it's an ongoing sort of partnership
process. Yeah.
Yeah.
If there has been some progression in this situation, is it Colombo-centric or is it island-wide? Be it treatment of HIV victims and acceptance of communities as well.
Well, I mean, it starts from Colombo, and then it slowly sort of spreads out to other sort of other areas, depending on what type of vulnerability we're talking about. Because it's very difficult. Again, it's very sort of, it could be issue specific as well, the kind of acceptance. But again, because we have sort of learned persons also who has the capacity to look at or sort of rationally look at different scenarios, we've seen when doctors, for example, have and get this exposure, also have mentors within the program itself pushing certain interventions forward. And when they do move to certain other parts of the country and take up their own responsibilities, then it starts to create a gradual, progressive change.
Yeah.
So it's a tough thing, but also look at it this way, right? Like, again, because of the amount of resources we have to, unfortunately, we have to prioritize where some of these services are going to. And it's sometimes easier to implement things in Colombo because we have a large amount of population that is vulnerable to HIV, as well as sort of the other intricacies around it. And it gives us a, I don't want to say playground, but rather the opportunity to try out certain interventions without terribly sort of rattling the status quo.
Yeah. Yeah.
And then if it works, then it's a matter of taking data and showing it and saying that, look, it works here, it could possibly work there. So why don't we slowly start then introducing these interventions?
Yeah, thank you, Mr. Shriyal. This next question is to Dr. Aryatna once again. What advice can be given to the sexually active youth on sexual reproductive health and testing? Dr. Aryatna? Right.
Yes. I'm talking as a medical person, a doctor. Right now, so if for young people who are sexually active, this is what the advice that I should give. I think you should limit your sexual activity to one partner who is also having sex only with you. Otherwise, if you are limiting to one partner and that partner is having many partners, that also won't work. Okay. So that will prevent, minimize the risk of getting STIs, including HIV. Okay. And then always think twice before starting sexual relationship with a new partner. Okay. So it is always good to discuss about, their past partners, history of STIs, drug use or whatever. It's always, before having sex with a new partner, always better to have a discussion about these things. And also consider having, sexual activities other than vaginal, oral, or anal sex. There are a lot of other sexual activities for young people who will get the almost same sexual pleasure without, exchanging body fluids between two people. Because the idea is to minimize the risk of getting STIs and HIV. And also, it's highly recommended that you use a condom. If the partner is, casual or you don't know much, or whether you are not long-term mutually monogamous partners, always better to advisable to use a condom. And also, for young women, girls, better not to douche after having sex, because that might, push certain steep eye pathogens further up. It won't cure, and also it will disturb the vaginal environmental, and it can lead to other diseases like bacterial vaginosis. And also, better to be aware about your partner's body. Look for signs of, any sores or wounds, blisters, rashes, or discharge before having sex. And also, you have to be mindful about your body as well. If there are these signs, always, seek treatment from a healthcare provider and request for a STD test, HIV test, and be frank about the healthcare provider that you had, this kind of exposure, uh, this many days ago, so that your healthcare provider or the doctor can decide what is the best test that can be recommended, or whether rather than testing, whether there should be, any antibiotic should be given to prevent any, curable STIs. So I'm seeing, this kind of young people who are sexually active almost every day in my practice. So sometimes some people do not, even with the doctor, they are not trying to be frank. They don't tell the. So you have to ask several times. They say, I said, have you had sex recently? No, long time ago. I said, how long ago? How many years ago? No, 1 month ago, they say. So likewise, they are trying to, hide even from the healthcare provider. So it is the best interest of, you have to give the correct information to the healthcare provider so that provider can recommend the best test suitable for you. So whether it can be just an antibiotic just to prevent any curable STI. So be careful about your partners and yourself, and that is the best advice that can be given to young people who are sexually active as a doctor.
Thank you, Doctor. This next question goes to Mrs. Shreya once again. As someone who is positive, what advice can you give to the members of the general public in order to assist them to be a part of a more positive dialogue in acceptance and integrated living?
Okay, I will give this advice as not as a positive person, but I'll give it as a person who is older at this point, has a alternative viewpoint on sort of life and relationships and sort of all of that, encompassing sort of being part of the queer community and all of that. My advice is that, okay, you start off quite young to explore your sexuality. I mean, I would like to, as much as I acknowledge doctors' advice on certain things, I do understand that some of these sort of precautionary measures are very sort of heteronormative in its sense, in sort of upholding monogamy and things like that. We do live in a time that prevention methods have been expanded to not simply just one preventative method. So, I mean, look at it this way. This is the analogy that I keep saying. If you like to cook, you need to be able to sort of take on the responsibility of cleaning up as well, right? Like cleaning the dishes inevitably comes as part of cooking. Similarly, taking care of your sexual health comes as a part of your exploration in your sexuality. And that's an inevitable sort of responsibility that you need to take on. So, which includes sort of breaking down your own fears of accessing these services, expanding your knowledge about what is most up to date, sharing that information with your friends, and asking people who are sort of out there about other possibilities of safeguarding yourself. One thing I would say, if you can subject an entire country to your subpar dance skills on TikTok, going and getting an HIV test or an STD test shouldn't be that much of an issue, right? Because I mean, it's so like it's not only going to keep you safe, it's also going to keep everyone else safe, and it's also going to add to the pleasure to understand that you are a responsible person. I mean, like, and it doesn't. Okay, so I'm beginning to shift my understanding on sort of unprotected sex, but to shift the narrative around condomless sex. Like doctor said, condomless sex is possible even with a person who's living with HIV, as long as the necessary sort of precautions that are required to are met. So knowing these sort of different layers of protection as a part of your knowledge arsenal around sex, similar to your other knowledge on how to pleasure your partner, which is a skill that is learned over time, taking care of your sexual health is also a knowledge that you gain as a young person. So expand it. And we are in an evolving sort of time. So just be informed, share the right kind of information, and also like be kind, stop perpetuating hate. I mean, we're all here trying to explore our own sort of lives, and just don't try to stand in the way because someone else's ideals do not sort of tally with what has been taught you by someone completely different to you. So unlearn some of these things and sort of always be kind.
Thank you, Mr. Shreyal. We've come down to our last two questions. This next question goes to both our panelists. We'll start the answering with Dr. Aryaratna. Dr. Aryaratna, what legislative mechanisms and whistleblower policies are in place to protect victims of discrimination?
Well, I think Sial must be a better person to answer that question. Actually, any discrimination based on whatever thing is cannot be acceptable, and there should be a way of addressing it. But unfortunately, certain things are not in systems are not in place in countries like ours. So I'm sure, depending on the place where that happened, the affected person should inform the head of the institution of that one. And for example, if the person concerned is registered in Sri Lanka Medical Council, for example, I think we can complain to the medical council as well. And best thing is to get as a group try to make this case so that it will be more effective, and then the people who are empowered, to those who are in authority, cannot just ignore it, saying that this is just one person's or the behavior or something like that. I know it's a challenging thing and it can be frustrating, but most of the rights people have won as a result of this kind of activism, whatever. So this is also part of this. So it is not so. Other than that, we don't have any specific policies. I mean, we have general policies to safeguard the rights of people, but I don't think we don't have any specific policies. But in countries like developed countries, they had very specific policies earlier developed, criminalizing HIV transmission, willful transmission and all that, but now they are keep on repealing it. But we never change our policy, so we don't have to repeal anything. But we have general laws which protect people. And so I think people should get together and make noise so that eventually, most of these discriminatory things can be minimized. And also, we have to raise the awareness among affected people about their rights and what are their, the strengths or whatever, and then that will minimize the internalized stigma among them. So then only they will come out of their hiding places and try to make a voice. Okay.
Thank you, Doctor. Same question to you, Mr. Shreya. What legislative mechanisms and whistleblower policies are in place to protect victims of discrimination?
Okay, so I think what we usually sort of refer to back is the fundamental rights chapter.
Yeah.
However, now you have to understand, again, victims of discrimination in this situation almost always are part of another vulnerable community. So if, to pursue a legislative, so okay, one is the fundamental rights chapter. Then there are multiple policies around sort of HIV and the workplace related sort of stigma and discrimination, and how sort of workforces can sort of make spaces much more acceptable. There are sort of other guidelines around sort of the HIV treatment programs and things like that. And then you have to understand what are the kind of discrimination that are we talking about? Is it sort of losing your job? Is it losing where you live? I mean, these are real problems, right? When people find out, they will find ways to sort of go about refusing certain services to you because of your HIV sort of status.
Yeah.
But that has a large impact on your entire livelihood. So you can refer to some of these mechanisms. However, starting any legislative process and through down the line, you will have to divulge the fact that you're living with HIV. You will have to divulge the fact that you are part of a vulnerable community. And if you're not someone who has or is willing to sort of do that, no legislative mechanism that is like completely sort of that encompasses your discrimination can account to the social challenges that you have to then negotiate by requesting for justice for what has happened to you, right? So it's layered. Again, it's layered against people who will be facing issues, because not only are you then forcing them to come out, but then their families, because I mean, sometimes people's attacks on you are entirely sort of outside of the HIV or your community. Yet when there is social value and there is social power to manipulating that sort of vulnerability that you have, they will go at it. It's like low hanging fruit, right? Like if it's like, okay, so like it's, for example, sort of insulting someone based on their sexual orientation when that has nothing to do with whatever the conversation is about. Similarly, you things like this will and can be used against you to discredit you to sort of further discriminate you, which is rather unfortunate. So without sort of addressing these other social barriers that are there among people and among communities, simply sort of any level of reconciliation for HIV related discrimination means no value. So it's you have to address it in multiple sort of points.
Before I move on to the last question, if I can present a question to you on my understanding of issues. When it comes to vulnerabilities in the society I've experienced, I've seen that people are very dismissive of vulnerabilities. And there's a toxic environment built around that dismissiveness. How can we fix that? Where is the solution to that? I mean, how effective is discourse? Because now we spoke about legislature. How effective is that in the long run to diminish this toxic belief system that when you are vulnerable, to just shun it away? That's not an issue. Why are you bringing this up? Pansy, all of these words that are thrown around. What is a long-term solution to fixing these things? Because it's a cultural issue, and it's something I've questioned a lot, which is why I'm presenting it to you, just to understand, in your opinion, how can we address something like that? Because I mean, even when it comes to this platform of discourse, it's only people who choose to looking at it.
Yeah, I mean, this is limited to English language. This is limited
exactly,
to
yeah.
a learned audience. You have to understand what discourse means to understand this conversation, right? Like,
Yeah.
Like, but let's put it this way: in the long run, Ritika, like, how old are you?
I'm 19.
And what is your life goal for the next 10 years?
I'd like to get into politics in the country.
Right. See, now, this conversation is being had with someone who potentially may have some level of say in how future legislature or future programming or future sort of conversations should be directed at, right? So
Yeah.
you're laying certain foundations for change that may not result in the next decade or so. And in the next decade, we may not be talking about HIV, but yet you will be pushed forward to society with the understanding that vulnerabilities of marginalized communities, regardless of where they come from, need to be taken into consideration if you want larger sort of social harmony. So, in an essence, these conversations being had with people who may move towards certain areas in society, and that may be anywhere in society, can then lead to sort of some level of systematic change, right? I mean, it may be someone who wants to provide training for nurses and then telling them, you know, look at people a little more humanistically. And it's one conversation to another conversation. And then it's also sort of, I think, humanizing the issue, right? This is also the other problem, that as long as it doesn't affect me, why should I care about it? Because I have 99 problems and sort of being gay is not one of them. So, but then what if my best friend is queer? What if my brother or sister is queer? What if like someone in my family, like my niece, my nephew is queer? Now that becomes my problem indirectly. So now I have a face to this issue. I have a emotion attached to this issue. And then that leads me to then take a different approach to what I have always done, or give me a completely different perspective of it. So these are some of the sort of strategies that we try to use for our advantage by trying to show that, and also like some people, you have to put it in a rational sense. Like say you, like it's a public health issue. Like in a country like ours, where we provide free medical services to every single person who's living with HIV, including their testing and treatment for their entire lifetime, like perpetuating hate and stigma and potentially increasing our numbers of HIV cases is bad for the country. It's bad for the economy. It's bad for healthcare systems because you are sort of burdening it. And here, like that might be something that is convincing to someone who's looking in a sort of completely different angle. So it's not one approach. It's different approaches for different systematic changes.
Yeah.
And yeah, so it's again, it's an ongoing sort of progress towards a community that we envision to have the least amounts of tensions.
Yeah.
And trying to be sort of as vague and like sort of general as possible, because like something where anyone can feel accepted to come in for services, don't feel sort of fearful to sort of come to terms with it, or accept, like even these understandings of coming to terms with it and things like that, like you don't come to terms with diabetes in that sense. Like I don't go and like sit to my best friends, like, you know, like our partners, like I have to tell you something, I'm diabetic, like we will have to start using insulin soon, is not in the vernacular of us, but it's reframing these things.
Thank you, Mr. Shriyal. The final question for both our exceptional panelists. In closing, what advice can you leave our youth and members of the general public to empower us to be a part of the positive dialogue? And what direction can you give us to take effective action to be a part of the solution? I'd like to start off this conversation with Dr. Ariratna.
Well, I will give you a very brief and very focused answer for this.
Yeah.
I think we have to accept there is a variety in the society. You know, people are all different. So there are things like, you know, mainstream people, I mean, majority of people, you know, that is also a relative term. For example, if you go to a Western USA, for example, you know, white people are majority, whereas in African country, it's the black people majority. So likewise, there are, you know, majority people and mind, but we are living in a world where we are living with different kind of people. It can be ethnicity wise, it can be sexual orientation wise, it is disease stage wise. So, and so we don't have to, we have to accept the fact that people are different. So accepting that, we can, you know, get rid of a lot of you know, unnecessary problems like, you know, gossiping and, you know, because it's all different at the end of the day. And we can, you know, only in that context, we have to, you know, refer to whatever the relevant things address. Otherwise, if you are, for example, if you are just my work colleague who are working next to me, whether you are, you know, gay, bisexual or whatever, or whether you are HIV positive or negative, doesn't matter. What matters is your working partnership. Whether you do your job according to according to our agenda. I mean, according to the responsibilities. That is what matters. So everything else is just not immaterial. And if you think like that and accept other people can be they can be different from my values and my whatever type. So then these issues are minimal, and we can live live in harmony without too much of a problem. So the problem is we resist. We want everybody to be our type. So that is where all these frictions arise and issues arise. So accepting that variety is the norm, and accepting that will create a lot of, solve a lot of problems. Thank you.
Thank you, Doctor. And in closing, Mrs. Shriyal, should I repeat the question for you?
Yes, I mean, very focusedly, I will also try to answer. But yeah, tell me, what the question was that.
In closing, what advice can you leave our youth and members of the general public to empower us to be part of the positive dialogue? And what direction can you give us to take effective action to be a part of the solution?
I mean, I would also refer to what Doctor said. People come in different shapes, sizes, and social backgrounds and cultural learnings and lifestyles, if you may. So finding it in yourself to treat people the same way you want to be treated is a good place to start, right? Like, I mean, if you don't want to be sort of treated a certain way, don't treat someone else that way. And always like update your knowledge and expand your knowledge. I mean, look, the world exists in its form and everything is perception. And we have sort of quantified it with how we want to see it. What I say may not be right, what you say may not be right, and neither may it may be right or wrong. So coming to sort of this understanding that I have never learned enough, and what I have learned today will inevitably shift tomorrow, is a good sort of way to sort of move forward. And we will never be in a time that we are perfect. So simply just sort of let go and be kind, treat people the way you want to be treated, and always be open to the possibility that you or your point of view or your learning could be challenged with something that come up tomorrow.
Thank you, panelists.
And I'm so sorry about like my Austin Powers moment with her, because if I just let her run loose, she'll just start wanting attention, and this whole thing would have not happened.
Completely fine. It's completely fine. Thank you so much, both of you, Dr. Ariratna, Mrs. Shriyal, for taking time out of your busy schedules to be with us here, inform us on things we do not know about. Thank you so much for being a part of this. This was Better Why, organized by the Rotaract Club of Colombo East and the Colombo YMCA. To all our viewers, if I can leave you with one word, or if I can leave you with a summary of what we just spoke about, we learned today that we all have a moral and social obligation to every single one of ourselves. We are a community, we are a civilization, and it is our responsibility to make sure that tomorrow when someone wakes up, he has to be hopeful in the world we live in. And we all have a say in this continuing for the future. We have the responsibility of future generations on our back, and we have to make sure, and we have to pledge to ourselves that we will care. And empathy will not be a word that we utter, but will be a practice in our everyday lives. Thank you so much, ladies and gentlemen, for being a part of these proceedings. This is Better Why, brought to you by the Rotaract Club of Colombo East and Colombo YMCA. Once again, reminding you of our sponsors, digital media partner, Daily Mirror Online and Lankadeepa, event partner, Flexus Labs. Thank you once again to our exceptional panelists, Dr. Ariratna Munatunga and Mr. Shriyal Nilanka, for taking time out of their busy schedules to be with us. Thank you, everyone who streamed with us live and will watch this video in the future. Thank you so very much, and a very good night to all of you. Good night.
Thank you. Good night.
Good night.